there's a lot of people who are like in this in-between space where it's like, I have this really bad pain, but I'm really not at the point where I need or want to have surgery. It's like, well, what do we do? And that's the perfect space for us. You don't have to wait till surgery. There's a lot of other things that you can do. And even if you think you're too sick to have a big surgery, there's a strong possibility that we can do things that can help you.
I think electrical medicine in general is the future. I mean, there is so many promising results, and people think it's a new thing. It's not. Cardiologists have long known about electrical systems in the body. This is something that has developed in pain management that's incredible. I do think that there is a lack of understanding, not just from the patient population and from a solution standpoint to pain, but also from other physicians.
Sure.
You know, there's been so many advancements in interventional procedures.
Not a lot of people know what a spinal stimulator is and what it can do for people. Give so many people quality of life, get people off narcotic medicines. Let's get the word out about all of these interventional procedures. Let's get the word out about how safe they are, about how effective they are, about how they can change people's lives without a pill. And let's make them more accessible too.
Welcome to Medicine Uncensored. I'm joined here today with Dr. Benjamin Sloop. Dr. Sloop,
good to be here.
To the show.
Yeah, thank you.
Just a little background and bio on Dr. Sloop. You did your residency in Virginia in anesthesiology.
Med school in Virginia.
Okay.
Came to Kentucky, to UK, did residency there 2011 to 2015. Worked on staff at UK as an anesthesiologist for a year.
Wow.
And then did the pain management fellowship there also at University of Kentucky. That was a year-long extra training focused in managing narcotic medications, these advanced pain procedures, and really a pain-focused and pain-centric year where we did a neurology rotation, we did psychiatry and hospice work as well. So it wasn't just the interventional pain, it was the broader picture of pain as well, which was really beneficial and really interesting. Was in private practice in Kentucky, the greater Lexington area for a few years, and then moved up to Cincinnati area to be closer to family as my own family grew.
And you joined our group.
Yeah, and it's been wonderful. I think we have, I was attracted to it for a couple of different reasons. Really a focus on the interventional aspect of pain management and also on the rehabilitation side of pain management. I've had a back surgery. I injured my back first time when I was like 15 years old.
This is similar to me.
This is crazy. Yeah. So doing the presidential physical fitness test in like 10th grade, I was doing the shuttle run, and they put two erasers down. You have to run, sprint, grab the eraser, turn around, and sprint back.
Yep.
And I dipped down to grab that eraser and twisted and turned, and my back just froze up. And
wow.
I felt weird, like as a 15-year-old, like I'm not supposed to be having back problems, but actually went and did really intense chiropractic treatment through a family friend and got better. And that lady, my parents still see her today. And she told me at some point, you're probably going to have surgery, which I did great for a long time. After that, I ended up playing collegiate soccer and running collegiate cross country for a year. Kind of had some flare-ups in college, but they were manageable with physical therapy and chiropractic and things like that. And then during my fellowship, actually, it got a lot more frequent and a lot worse, and I attribute that to wearing the lead vests and things like that.
That's very interesting. See, a 15-year-old, that is perfect for chiropractic.
Yeah.
That injures their back or whatever.
Yeah.
I would say probably a little too early for surgery at that age.
Yeah, unless it's absolutely like
necessary,
you're doing nerve damage or you're having cauda equina syndrome or some sort of really severe neurological injury. But yeah, I agree. You don't want to have surgery when you're that young on your spine.
Absolutely.
You want to put that off as long as possible, in my opinion. A lot of that has impacted the way that I think about managing pain. I recognize when a patient comes in with a herniated disc because I've had that.
Yep.
Like, I remember I sat like this. I remember what that feels like. And I still have in my foot like some nerve damage, and it's not bad. And most days it doesn't bother me, but there are days when it's really can be irritating. It gives me a little bit of a glimpse into what some of our patients might be going through, options for getting better and recovering. I've had epidurals, and then going through the process of having a back surgery and what it did for me. Like, I worship the ground that Christian Ramsey walks on because he's the neurosurgeon that operated on my back.
There you go.
I was on crutches. Going into the hospital that day, I could hardly walk. Like, I couldn't walk. I was on crutches getting into the hospital to have surgery that morning.
Wow.
I walked into my house.
And what age was this?
I was 30. Let's see, that was 2017, so I was 35.
Wow. And what was the procedure?
It was a discectomy.
Discectomy. See, this is what I've been fighting. We talked about this.
Yeah.
So Dr. Sloop, just so everybody knows, has done my epidural as well, because I had a similar thing when I injured my back doing deadlifts.
Yeah.
I don't remember actually if it was deadlifts or front squats. It's funny now because I've been fighting the surgery, and the epidural has held for me really well for the most part.
That's great.
And so, but it's funny, deadlifts actually help now.
Yeah.
You know, somehow there's something that's stretching there.
If you're doing deadlifts right, you can actually decompress your spine some there, and certainly not doing crazy amounts of weight, which can actually cause to make things worse. So having good technique and things, I think that it's possible to decompress your spine. But so that's kind of what drew me to this practice. Was we have a great integration of chiropractic and physical medicine. Also the role of the interventional procedures to help somebody get better. And it's been a wonderful partnership, and I think our patients are incredibly happy and satisfied with the results that they've gotten.
Well, you've done an incredible job. I just want to speak to that for a second. I mean, Dr. Sloop, just so everybody knows, is our medical director at Elite Pain Doctors. Super experienced, super smooth. You have done hundreds of neuromod cases, tons of bread and butter, epidurals, MBBRFAs, procedures called mild that we'll talk about, and all kinds of other advanced procedures. And so really impressed with your skills and ability.
Thank you.
To the point where I know other local surgeons are very impressed as well with your skills and ability, and really how you've developed your hands to be able to go in there and do what you do so well and so efficiently. Yeah. And it's impressive. So you've really helped grow this place and grow this practice, and we have molded into a new way of doing things with interventional pain, and you've really brought a lot to the table, so I appreciate that.
Yeah, it's been great being a partner with you guys, and just the vision for doing something different. It's hard. It's hard to break the mold. It's hard to say we're going to take a new twist on this. We're a freestanding entity. We don't get referrals from a big hospital or a big hospital system or a big network that are so prominent in these areas. Well,
let me speak to that for a second, because I don't think everybody understands that. So when I built this originally in 2018, I had just come to the area. You know, I was from Indiana, so there was no connections. I did not have hospital connections. I did not have connections with local docs, and we were sort of the new guys in town that nobody wanted to do business with, because we were looked at as, well, you're taking away from our patients. You're taking our patients, instead of, this is a place that we can utilize to send patients that are in pain and get them back.
Yeah. It's almost like you're seen as inferior if you aren't part of some big network.
Yeah.
And it's really not the case. No offense to anybody that works at a big network hospital or whatever, but like, there is so much bureaucracy and so many layers of getting this approved and this approved and this approved. It takes forever to offer something new. Whereas we're on the cutting edge of these things, and we can say, we want to do this. Okay. That goes through, me, the medical director, and the business ownership structure, which is just a couple of people, and we're doing it.
Well, and we have an entire team now that handles all the PAs and all the billing, and so super smooth.
We're doing stuff that we're light years ahead of a lot of the hospital systems and things, especially with like the mild that you mentioned earlier. We have docs who come here to do their milds because the hospital won't do them. We have people coming from hours away to do a mild because no one else offers it, and it's really silly. It's sad that these things aren't more widely available. And part of my personal mission as a physician in this pain management space is to get the word out about, and part of doing this with you, get the word out about these minimally invasive procedures that can help people who maybe aren't healthy enough to have a big surgery. or don't need one. Maybe there's a lot of people who are like in this in-between space where it's like, I have this really bad pain, but I'm really not at the point where I need or want to have surgery. And it's like, well, what do we do? And that's the perfect space for us. What I want to do is let people know that there are other options for you, that you don't have to wait till surgery. There's a lot of other things that you can do. And even if you think you're too sick to have a big surgery, there's a strong possibility that we can do things that can help you. And the example that I use about the spine stimulators is a pacemaker. Like, everybody knows what a pacemaker is. It's a household name. It's a household term. Everybody knows. Not a lot of people know what a spinal stimulator is and what it can do for people. And so I want to get the word out about these wonderful treatments that give so many people quality of life, get people off narcotic medicines, help people regain their function, their social interactions, all the things that are important to them. So thank you for having me on this podcast to help get that word out and help spread these things that are wonderful treatments in medicine that just aren't very well known.
Well, we're definitely going to touch on all of that because I think it's super important what you've brought to the table in these advanced procedures. And I do think that there's a lack of understanding, not just from the patient population and from a solution standpoint to pain, but also from other physicians.
Sure.
You know, there's been so many advancements in interventional procedures, just like the iPhones changed back from when it first came out.
Exactly.
And it was all grainy, to nowadays where it's a entire freaking AI computer, basically. There's been huge advancements. And so I want to talk about all that, but I just want to back up for a second. I want to know what drew you specifically into anesthesia and pain management?
Yeah, so I've always liked working with my hands. I grew up kind of on a farm, and we fixed things.
Where was this at?
In Virginia.
Okay.
I broke many little bicycles and dirt bikes and go-karts, and we didn't have the means a lot of times to take stuff to be fixed, and we had a barn full of tools, and so it was like figure out how to fix things. And so that's kind of ingrained in a bit of who I am, is how do you fix something, and working with your hands and taking things apart and putting them back together. And so when I'm thinking about medicine and my career and what I want to do, a lot of it was something I can do to work with my hands, and anesthesia is a lot of that. It's intubating, it's putting in lines, it's doing nerve blocks, and then there's the whole pain aspect of anesthesia. And I also really enjoyed like physiology. You kind of have to be a physiology nerd to like anesthesia. And anesthesia is this really cool specialty where you have to know a lot about everything. So you have to know a lot about pediatrics. You have to know a lot about pregnant women. You have to know a lot about obesity. You have to know a lot about cardiac, heart. Like, you have to take care of everyone with all these different conditions.
It involves all the systems.
Yeah, and there's not a lot in medicine. So I have this, anesthesia gave me this awesome foundation in physiology of everybody. And I use that all the time in our clinic now, even though I'm not directly doing anesthesia, but I'm thinking about the anesthesia for our patients who are going to have surgery. So I'm forever grateful for this incredible basis of knowledge of everything in the entire hospital ecosystem that anesthesia knows and manages. And then the pain, but doing anesthesia, I kind of missed like a relationship with my patients. That's kind of what we were talking about before we turned on the cameras. I missed the aspect of getting to know someone.
The personal touch.
I missed someone coming back and saying, hey man, that thing that you did for me really helped. And
now you got to show everybody your cup.
Yeah, this is a mug that one of my patients back in my first clinic made for me, and it says, thank you, Dr. Sloop, for having Glenn's back. And Glenn, I did a lot of epidurals on him, ended up getting him in to see a surgeon. He had a fusion on his back. He was dramatically better. Wow. And this is like my coffee. She made me another one that I have at home. That's the mug that I drink my coffee out of every morning. So, and it's that kind of thing.
It's the impact. You obviously made an impact there, and they appreciate it.
Yeah.
It's changed his life.
Yeah, and I think pain management is a little bit known as being a little bit of a harsh specialty in terms of, just the narcotic medications.
It's gotten a bad rep.
Yeah. And getting dismissed from somebody's practice because you saw another pain doctor or whatever, kind of territorial and things. Yeah. And there's room in all of our lives and in all specialties of medicine for kindness and empathy. And I think sometimes we forget that in our training. It's all about doing this procedure and doing it right. And those are incredibly important things, but there's also the human touch and the compassion, and realizing that when someone comes to you for a chronic pain problem, that they've been to their family doctor for years about this problem.
Yeah.
They've been to physical therapy for years about this problem. They bought everything on Amazon to help them with this problem, and nothing's helped them. And they've seen the orthopedic surgeons, and no one's given them an answer, or no one's been able to give them a solution that works for them. And being able to realize that in a patient, and bringing some kindness and empathy and say, hey, look, I realize that you've been through all of this, and that this has a dramatic impact on not just on your life, but like your sleep and your family and your job and every aspect of your life. And try to offer a solution. I try to have a solution for everybody that comes in.
I think that's so important.
Whether or not they want to take it or not is up to them, but I pretty much have an option for you that can help you. I like to think that I do it, at least, I guess. But integrating that personal touch, that's really one of the big reasons for me to get into pain management. Was I just kind of like to talk to people and be social and things, and I really miss that in the anesthesia world. You put somebody to sleep and then they're not talking to you, not interacting with you, and you never heard if you did a good job or not.
Well,
or you never got any, there was no relationship there. And so pain has really been a great, I love my job. I love what I do. I love the procedural aspect of it. I love seeing our patients. I love answering their questions. I love helping them try to get their lives back on track.
There's a couple things I want to touch on.
Sure.
That you brought up. Number one, this idea that, pain management sort of has gotten a bad reputation over the years, mostly due to the opioid epidemic.
Yeah.
And there's been some bad actors. Purdue Pharma.
Sure.
There's been some things along the way, but I want to talk a little bit about your experience in pain, because you had brought up that you had originally worked at a smaller clinic, and were doing pain management there, and now you're up here. So tell me a little bit about how your career has evolved in pain.
So when I'll never forget this. I was starting in my first job, and was going around to some orthopedic offices and talked to an older orthopedist there who was just a couple of blocks from where I was working. And he said, are you going to write pain medicines? And I said, well, I prefer not to. He said, well, you're going to fail if you don't write pain medicines.
Because
you're not going to be around very long.
I want to point out, and there's nothing wrong with it, there's a lot right about it, but orthopedic surgeons, they want their patients to be able to get that relief.
Yeah, they want access to that.
And they know
if
what
somebody
they
needs it.
know about
Yeah.
pain management.
And so
not necessarily experts at pain management, they know what they know about
sure.
pain.
And they know when a patient's kind of max out on their therapies, and when something else is going to help them. And I agree with that. But I was a little bit like, oh man, he's right. In fellowship and in your training, you kind of have these rose-colored glasses on of what your job's going to be like and all these things. And it was a heavy Medicaid type population. I served a pretty rural area there in Lexington, kind of going east towards the mountains, and we were really like the first reasonable sized medical center. So we had patients driving from hours away because we were the closest pain management clinic. And so I did a lot of med management, and I don't think that was a bad thing. I think that was something that patients needed. Yep. And I thought that it was a good service to the community. And I did epidurals, and I did stimulators, and I did radio frequency ablations and nerve blocks and all those type of things. But I think, I never saw an opioid change somebody's life.
Yeah.
It was well, it takes the edge off.
Yeah.
There's frequently side effects. Well, now I'm so constipated. What I do? So I treated a ton more constipation than I ever thought I would treat.
Yes.
As a pain doctor, or it's making me drowsy, or there just always seemed to be some sort of side effect, and it never really seemed to
There's not miracle results attainable.
Yeah,
really.
It just always seemed like it was never. It was a pill that was a Band-Aid.
Yeah.
for a solution, for a situation, and that pill only lasted for a few hours, if that. A lot of people would say, I get a couple of hours of relief out of this. And, at the same time, I started working with an addiction clinic kind of on the weekends, like doing some just like part-time work there, helping them out. And gave me a really different perspective on the opioid epidemic and kind of the situation with narcotic medications, and would help those patients with what's called MAT, or medication-assisted treatment. And so I prescribed quite a bit of a medicine called buprenorphine, which is a wonderful medicine for someone who has some sort of an opioid addiction or struggling with those things. And really, that really changed some people's lives. And it was a good practice. I felt like I was helping people, but also kind of wanted to step away from some of the narcotic stuff and get involved more in the procedural side of things, in terms of the stimulators and the milds and the intercepts. I mean, these are things that can really help someone on a really like a permanent type basis, instead of being a pill that you have to take that can get stolen, that can get lost, that you can overdose on even. And so that's really, my practices kind of switched in a big way from being something where I was writing a lot of pain medicines and things to something that's now mostly procedural, based in, really this cutting edge. But I'll say this too, in that area, I didn't have access to a lot of the bigger procedures.
Of course,
the companies have reps.
Yep.
And when you're in a smaller area like that, like I tried for a long time to get people from the spinous process fusion devices they wouldn't even email me back because I wasn't in an area where there was a rep where they could support it. So it's kind of hard to get traction in some of those areas. I think that is changing, and I think it has changed over the last 5 or 6 years, to where these minimally invasive procedures are becoming more commonplace, and the companies are growing and are able to put more reps in the areas to provide the support that they need. So I think that's a good thing.
So Dr. Sleep, I want to talk about some of the procedures that we do and some of the solutions that we offer people. So for failed back surgery syndrome, for neuropathy, walk me through what it looks like for a patient and what that experience would be like for them to come in and go through the trial and implant process. What does that look like?
Sure. So a lot of those patients are getting neuromodulation or a spinal cord stimulator. So really, patient comes in with typically some sort of neuropathy type complaint, burning, tingling, numbness in an extremity. We work that patient up. We try to determine the cause. Frequently, these patients have spine issues or are diabetic. Those are probably the two biggest.
And diabetes is huge. That's like such a growing number these days.
Yes.
With the baby boomers.
And a difficult thing to treat as well. So these patients typically have been through, gabapentin, Lyrica, antidepressant medications, topical creams and things like that, and really have either had a side effect or not much relief. So the process for us is you'll have a consultation there in the clinic. We take x-rays. We present kind of our plan to the patient. And typically with those type of patients, we're offering some sort of spinal cord stimulation or neuromodulation. And a lot of this is insurance requirements, but we send you for a psychological evaluation. I think it's silly that the insurance companies require that, but it is what it is.
To be clear, it's ridiculous. And it has nothing to do with whether or not they are a candidate, but it is a hoop that we jump through.
Correct. And I think that should be something that I get to determine as the physician and say, look, this person, is clearly sane from a mental standpoint. They're normal in every way, shape, or form.
Well, to our theme on Medicine Uncensored, it's a complete overstep of the insurance industry.
Sure. Yeah.
This is a decision that should be made by a doctor.
Yeah, and I think I should be able to have a say in whether or not someone needs that. But anyway,
course.
It is what it is. It has to get done. Then we'll typically order some sort of advanced imaging of the area, typically an MRI or a CT scan. And we're making sure that there's no gross abnormalities there that would prevent us from doing the procedure, maybe even make it dangerous for you. That's very much a safety kind of thing. And every now and then we find something unusual on there. We have to say, look, you probably need to go see a neurosurgeon about a syrinx or a cyst or something unusual there. And we have some good relationships with surgeons that we can send people to for those consultations.
And I think normally on the guys that we send to go get MRI, because it's often now, it's become a requirement for almost for a lot of our procedures, even epidurals at this point, which again, it is what it is and is an insurance thing. But I think some people have, and this goes back to, probably 5-10 years ago, people were very worried about getting advanced imaging if they had a heart condition like a pacemaker or whatever. And I believe nowadays they're still able to get, in most cases, an MRI or a CT or something.
Yeah, so depends on how old the pacemaker is. Certainly there are some newer ones that are MRI compatible, but most of the older ones are not. And so if that's the case, we have to get a CT scan or a myelogram sometimes. But
the door's still open. There's still a solution.
Exactly, and there's ways to overcome those hurdles. I won't say that it's an absolute necessity for everyone, but it is something that we try to do for a majority of our patients. And it's just a safety kind of check there to make sure that there's nothing there that's going to prevent us from having a successful trial.
Right.
And then we get lab work. We want to make sure that from a whole body physiologic standpoint that there's nothing outstanding there that would concern us. If you're diabetic, we're checking your A1C values, seeing what your blood sugar control has been over the last couple of months. And then once we get all this information, we send it to the insurance company to get their approval. That can be anywhere from a couple of days to a couple of weeks.
Yep.
And the patient is then notified of the date of their trial. The trial is really the crux of the spinal cord stimulator. And during this process, it's all done through a needle. There's no incisions. You're given a little bit of, we'll say, relaxing medicine to help you tolerate the procedure. The procedure really only lasts about 15 or 20 minutes in most cases. We do use an X-ray camera, and it's done here at our surgery center, so there's some safety built into that as well. But we numb up the area on your back around T12L1 area, depending on what your spine looks like, and hardware and other things there. Then we advance a needle into the epidural space, and then again, that just takes a couple of minutes. When the needle's in the right spot, we'll then advance the lead or the wire into the epidural space. We'll typically place 2 wires to typically kind of cover both sides of the back or legs or feet. Once those are in, we'll take the needles out, leaving the wires in place, and we tape everything down on the patient's back. In terms of, people always want to ask, like, how bad is this going to be?
Right.
Hurt? Is this super painful? Really, in terms of all the procedures that I do, it's one of the ones that I get the least complaints about being painful or uncomfortable
it's similar to an injection.
Yeah,
it's
basically an epidural injection. And so it's generally very well tolerated. After that, 20 minutes or so of putting that in, we keep the patient in our holding area, which is this room that we're in right now, and a representative from the device company will be there. They will turn on the system and they'll do some mapping. And that is that they turn up a little bit of stimulation there in a way that the patient can feel it. And we're making sure that the patient feels that stimulation in the areas where they have pain.
So it's a check to make sure it's working.
It's a check to make sure that we're in the right spot. And sometimes people have really bad like scoliosis or kyphosis. It doesn't mean that this procedure can't be done, but what it means is what we see as anatomical midline may not necessarily be actual midline for the patient. And so that can help check that as well. They'll teach the patient how to use the device. There's typically a little remote control, and it's pretty basic. There's an up and a down button and an off and an on, and maybe another button where they can cycle through some different programs, but it's all pretty basic. Then we send the patient home. They get to keep the device for a week and try it for themselves. And I really think that that's the key to all of this is, during the trial, are you able to get good relief, and are you able to be more functional? Are you able to sleep better? Are you in a better mood? A lot of times people's families will say like, hey, I've noticed like a big change during this week. The goalpost is 50% improvement. Certainly, majority of our patients that do the trial report more than that.
And so just to clarify, so I just want to summarize, because
Sure.
we went over a lot of detail there that I think most people have not heard before.
Yeah.
So patient comes in, they're getting an exam, they're getting consultation, they're getting exam, there's some imaging, some other imaging is ordered and then done, some other testing, blood tests, psych tests, etc. All the PA and stuff is done by us. So for the patient, they're coming in for a visit.
Yep.
They may need to report to an MRI or a lab to get
Yeah.
blood. And this whole cycle takes place. So from the patient point of view, it's pretty simple. You're showing up, you're doing your imaging, you're doing your testing.
Yep.
We get it approved, you're coming in, 20-minute procedure.
Yep.
They're recovering. Are they able to drive home same day? Are they able to walk out on their own? Is there recovery?
Usually they're walking out on their own. Because we do give a little bit of like sedation medicine, we tell them not to drive for the rest of the day.
Yeah.
That's a safety thing. We don't want anyone getting in a car accident or getting hurt. But then typically it takes the stimulation a day or two to kind of build up in the system.
Sure.
And then your back can be sore it shouldn't be anything that's terrible, but a little bit of soreness there is not uncommon for a day or two after the procedure. And then usually by the second or third day of the procedure, patients are getting a lot of relief. They're doing a lot of their normal activities.
Yeah.
They're kind of testing it out. I want to go to the grocery store. Can this help me when I'm trying to cook or clean or do some activities at home?
And the patient's going to tell you whether or not the thing worked. At the
Yeah.
end of the day, the patient's going to say, okay, this worked for me and I feel at least 50% better, or it didn't work for me and I don't feel 50% better.
Correct.
So let's say the patient, it did work for them. They got at least a 50% improvement, which is a huge improvement for most people.
Correct.
If that happens, walk me through what happens next.
Yeah, so you'll come into the office for a lead pull, okay? The wires come right out. It's not a painful thing at all. Usually we take the tape off, the wires pull out.
Right.
It's like pulling the tape off is more painful or more uncomfortable. Patient tells us they want to proceed. We get them on the schedule for the surgery, for the permanent implant, the permanent version. Usually that's done within a month, I would say, for most patients. Again, that's a small surgery that we do here. It takes us about an hour. For that procedure, there's 2 incisions, okay? And this is basically so we can just hide everything underneath your skin.
Yep.
The first incision is in kind of the middle part of your low back, okay? Once we make that incision, it's typically no more than an inch or so deep, and we're not going into the bones, we're not going into the muscle, we're not going through anything there. We then put the needles and wires in just like we did for the trial. Okay, we take the needles out, leaving the wires in place. We put it like a sleeve around that wire so that we can anchor it down to the strong tissue there to prevent those wires from moving or migrating. Then we'll make the battery pocket. People usually, I find that it's the most comfortable position is on the side. We let people choose which side, and we kind of tailor that to each individual patient where that would be most comfortable for them. We certainly don't want that over your belt line, over your waistline.
Sure. But just so everybody knows, if you haven't seen one of these batteries before, generally we're talking about something the size of about an Oreo.
I tell people, yeah, a double stuffed Oreo cookie
Yeah.
is about right.
So it's not a huge thing.
Very
and
small.
We're still in the zone of minimally invasive here.
Absolutely, absolutely.
Yeah.
Tunnel the wires underneath the skin to the small battery, connect it, turn it on, make sure that everything's functioning appropriately, and then close up. It takes about an hour. The recovery from that is pretty minimal. I would say that I write usually a couple of days of pain medicines for people. They usually don't require any more. The biggest complaint, if there is one, is just it's really sore back there, and pain medicines don't really help great with that anyway. We do have people on light restrictions for about 6 to 8 weeks. We want to give your body time to heal and for scar tissue to form around the wires.
So that they don't pull.
Yeah.
Makes sense.
And then, back to normal life after that for the most part. Not a whole lot of restrictions. People ask about, is this going to keep me from doing all these things? So no, really the idea is for this to help you so you can get back to doing those things and not be dependent and reliant on taking a pill every day or coming into a doctor's office every month and doing a drug test and things like that. And I will say, I get very few complaints. Most of our patients with our stimulators are very, very, very happy. It's been a very rewarding opportunity, a very rewarding therapy to offer patients who have struggled with these problems for years and have not had good solutions.
I think it's really important, just to further emphasize how incredible of a solution that it is, that we dive a little bit deeper into the science on
Okay.
some of these devices.
Let's go.
So let's nerd out a little bit and let's talk about, you hear these terms that get thrown around by some vendors and companies and other things on the internet about burst and closed loop and some of these other technologies. So can you speak to a little bit about what the spinal cord stimulator is doing to the body and how that is working and affecting this situation where the patient gets relief?
Yeah. So let's start with a little bit of a history lesson. So stimulators, the first one was done in I think 1967 at Case Western. A guy had just had lung cancer, and cancer pain is terrible. It's one of the most difficult things to treat. And the guy was just resistant to everything. Nothing was helping him. And there had been some folks there who were researching electrical energy on nerves. And so they said, man, this is the great opportunity to try this therapy on. So they put a lead up. It was just the lead. There was no battery implanted. The battery device was external, and he had just amazing pain control. So that was kind of the first thing that got the ball rolling on simulators. Became a much more widespread in the pain community in the 80s. That technology then was paresthesia based, and what that means is you would feel a tingly sensation that would mask your pain or cover up your pain. While it helped pain, it introduced some other problems, maybe we'll say, is if you moved a certain way, you could get a jolt or a shock, or maybe it wasn't as effective if you moved in a certain position. It would
Not
be
quite as safe.
more effective if you were laying down, and then they would even tell people hey, you shouldn't drive while it's turned on. Worried someone would get a jolt and get into an accident. The technology has dramatically improved, and I'll say probably around 2015, 2016, a company called Nevro came on the scene with what was called a high frequency, 10,000 hertz, which is a very fast, rapid amount of energy. And they found that with that amount of energy, that a patient didn't experience any of that tingly sensation, and it helped their pain. So that was kind of the first big jump from this paresthesia-based.
And 10 hertz was almost, if I remember right, 10 hertz was quite a lot more energy.
Dramatically more than anyone else was, yes, way off the charts high.
Yeah.
It helps your pain, but it also isn't interfering with anything, and it works more all the time and isn't as positional and things like that.
So you're not drowsy, you're not constipated because you're on painkillers. Well, you might still be on painkillers, but let's just say you're not. It comes with less side effects.
Correct. And it's really tailored to your personal preference, and it's not like a pain medicine where it's okay, you're getting a 5 milligram, okay, you're getting a 7.5 milligram, you're getting a 10 milligram or whatever. The amount of energy and the frequency that we can use is so unique and individual to you that it's really, I think, an individual therapy. I think that this can be tailored to exactly your preferences, and the possibilities with programming these are astronomical. So it was became this breakthrough thing. Well then, and they did studies. There's this studies that Nevro did on their technology showing that this is as effective or more effective than traditional stimulation, and kind of really shocked the rest of the spinal cord stimulator market,
it's a
if you will.
breakthrough.
Brand new thing, brand new company, kind of disrupting everything, so we say now. Well, the other companies, I think, were kind of oh man, we got to figure out a way to make this work. And that is where the burst technology comes in. And this is actually kind of a crazy story. It's called burst DR, and the DR stands for Dirk de Ritter. He's the guy who invented it. He's a German neuroscientist, neurosurgeon, who was working on tinnitus, which is ringing in your ear, which is a very difficult problem to treat.
Absolutely.
And he had discovered...
Think how maddening that would be.
I know, every day to hear this buzzing. He had found that there was a sequence that your body, that your nerves fired in your body. And it was this burst sequence where it was on for a millisecond or two and then off. He tried and tried and tried to get people to buy into this, and no one would hear him out. He had a resident put leads in him. He got on an airplane and flew from Germany to Texas to Abbott headquarters
Yep.
and sat in the waiting room until someone would talk
I
to him.
remember this story.
Yeah. Dr. Flowski told us this story
That's
when
right.
he came. And anyway, I think he talked to some low level, upper management type person there, and they took his stuff and kind of put it at the bottom of the
Yeah, I think he
pile
just
and
refused to leave.
Forgot about it. I think.
Yeah.
He refused to leave until somebody talked to him. But what a ballsy move to like.
That's what we need in doctors. I mean, that's incredible.
It is. People like that don't exist just in general.
It's a rare case. I mean, that is something.
But when the Nevrosenza study came out and the high frequency became a thing, Abbott said, "Oh man, we gotta like figure something out." And they remembered that he had come, and so they started investigating this and trying it. And lo and behold, this is this amazing thing that works, and it works great. It's very different though. It's a very low frequency, and you hear all this stuff. I don't really know that there's a lot of data to back this up, but people say that the really high frequency just kind of beats up the nervous system some, and maybe it's not as durable. I don't know that there's any real evidence to back that up. I think it's all people saying, well, a high amount of energy is maybe not good for a long period of time. I don't think I've seen that
We've seen a lot of success with Nevro.
Yeah, I don't think that we've seen that at all. But that is what it's important to know what the opposition says. It's important to know what
it is.
It's important to know the counter argument.
It's important to know that there's different methodologies, and at the end of the day, I think that like bodies are individual.
Yeah.
Not everybody responds to the same therapy the same way.
Exactly.
And I think and we can touch on this more as the conversation moves forward, but with where we're at now with AI and big data and machine learning and developing systems.
They're already working on that. Yeah, they really are.
Well, and they are. And so, systems that will utilize big data collected over decades of doing neuromodulation and successful and unsuccessful, and then the ability to get live biofeedback from a system.
Very important.
All of this, right? you could get it to where a system is theoretically dialed in perfectly for that individual patient. And I think that there have been a lot of advancements along that line, and I think that we're getting there.
Yeah, we are.
And I do hope that in the next decade.
I think all the companies are working on those aspects of things.
Yep.
So the Burst is a very interesting counterpart to the Nevro HFX. Again, using a lower energy, something that supposedly mimics your body's natural neural sequences, which I think is cool. The other interesting thing about Burst is that they think, and they've done studies on this, that it actually activates part of your medial cortex in your brain, which is where the emotional component of the pain is processed. And so they say it's independent of pain relief, that patients are experiencing improvement in their mental well-being because of the stimulation. Again,
I believe that neurosurgeon
independent
was talking about that at that dinner.
Yeah, independent of the fact that you get pain relief. And I think the argument is, well, duh, if you get pain relief, you're going to be mentally feeling better. They say that it's completely separate from that.
Yeah.
Not something that I would promise someone or try to convince someone to get a different stimulator because of, but I think it's an added benefit.
It's an interesting anecdote, and we'll see where it develops.
Yeah.
There's a lot of potential benefit, and I think that the layperson does not necessarily understand electrical systems in the body, and I think that oftentimes gets overlooked. You're like, I have back pain, and that's, it's not, the body has an electrical system, and the heart has its own electrical system. Cardiac surgeons know this very well. So does the spinal cord, so do many different systems. And so you manipulate that energy in the body, and you can get a whole lot of incredible results.
Yeah. So again, along those same lines, and this is, I think, another really interesting thing is the Nevro HFX folks have recently published, I just was looking at this last night and shared this with our advanced practice providers, is that people who have the 10K HFX system in place are getting improvements in their A1C, improved sleep quality, and weight loss.
Yeah.
And they're not sure of the mechanism there yet. Is it a direct mechanism of the stimulation? I think they're now investigating that a little bit more. But I think that the possibilities with nerve stimulation, spinal cord stimulation are absolutely incredible. And the future of this, we are really just scratching the surface. And there in the last 5 or 6 years has been this huge resurgence of technology into the spinal cord stimulation world. There are now trialing movement disorders with stimulation. So people who've had strokes or spinal cord injuries who have lost movement of a limb or an extremity, and showing some really amazing, promising type results. So not something that's currently offered, but I think there's great potential there for that.
I think electrical medicine in general is the future. I mean, there is so many promising results, and people think it's a new thing. It's not. Cardiologists have long known about electrical systems in the body. This is something that has developed in pain management that's incredible.
I think like back in Roman times or something, you should like put eels on people.
It's
eels,
true.
Right?
It's been around a long time, you know, and so it's just incredible. It's incredible where things are going. And I think that the solutions and alternatives to the more conservative things that have side effects and stuff like that, boy, the future's bright.
I just think it's more personalized. Like
it is.
If you know, gabapentin comes in 300, 100, 300, 800, 600, 800 milligram tablets. It's like, and that dose is just, they're kind of fixed, and sure, you can combine those in certain ways to get a different dose, but like, so many people just take like a 300 milligram 3 times a day or something. It's like, and it will work for a few, and then it's gone. And it's like, there's a better way to do this. And the stimulation, I just think, is so personal and unique to every individual that it really gives an opportunity for you to have something that's unique to you. And that's really uncommon in medicine.
It is. So there's different systems. So there's the 10 hertz. There's the closed loop. Do you want to touch on closed loop real
Yeah, so
fast?
closed loop is cool. It's a pretty new technology as well. And what this allows is it allows to measure the actual dose of energy that your spinal cord is getting and to keep it at a constant.
Yeah.
So we had mentioned before, like sometimes with the older stimulation, if you're in a different position, maybe you're, depending if you're bent over or leaned back, maybe that electrode is closer or further away from the spinal cord where the electricity is delivered. And depending on how far away that is, that energy that you're receiving is more or less. And so what this does is it measures continuously, like 60 times a second, the amount of energy that the cord is getting, and then readjusts to keep that signal and that amount of energy.
That's so
constant.
promising.
I think it's great because it's almost like delivering energy as a dose.
Can you tell me a little bit about Intercept and what it is? This is something that I know is unique to us in this area. I know it's a more advanced procedure, and we're seeing a lot of success for it.
Yeah, absolutely. So Intercept's relatively new. I'll say probably less than 10 years or so. You know who Carson Daly is?
Absolutely.
You've heard that name? Yeah, like for our generation.
For our
he was
generation,
like everybody knows him,
He was the host for everything.
For like MTV.
Back when MTV, I don't even know if MTV is a thing anymore.
Yeah, so anyway, he did a segment, and he kind of, if you remember, I don't know, I haven't followed his career super closely, as neither have you, but he like kind of like disappeared for a while. Well, it's because he had terrible back pain. He ended up getting.
I do remember something about that.
He ended up getting the Intercept procedure, and then came back to work and did a piece on, I can't remember what news network it was, like NBC or whoever he works for now, about Intercept procedure, and really kind of was the big boom and bringing Intercept kind of into the forefront of medical treatment and making it more popular. So basically, this treatment is targeting what's called the basivertebral nerve. Okay, this nerve actually lives inside of your vertebral bone in the front part of your spine. To date, we've had very little treatments for this anterior column type pain. And I remember in fellowship, we talked about discogenic pain, pain that originates from the disc, and that we just didn't have a lot of great
solutions
for it. And this is pain that's worse with movement and activity. So these people are like, look, if I'm I'm laying down or sitting still or not doing something, I'm fine. It's like I go to pick something up or do some repetitive, my back just kills me. And it's very, very, very painful. but it's usually worse with like forward bending and things. But it's a result of degenerative changes in the disc that then cause changes in the bone itself and irritate that nerve. We have to have an MRI to see those changes. I think you could argue that you could probably identify those changes on X-ray, but insurance requirement is MRI. And you'll see changes in the end plates of those bones, okay? We call those modic changes. I think that was the guy who first discovered them. The procedure is really quite amazing. It's a permanent procedure, okay?
Okay.
We take a port, we access the area of the nerve from the front of that bone using light sedation here in our surgery center. It's not a terribly painful or uncomfortable procedure for most folks. You put a heating element next to where that nerve is.
So we're going inside the bone through a port.
Correct.
And then we're heating the nerve.
Correct. And you're creating a lesion around that nerve to destroy that nerve.
Wow.
Okay. So it's a permanent type treatment.
Is this similar to like an RFA or?
Similar in the fact that it uses radio frequency and a heating type procedure to destroy the nerve, but it is a permanent burn. That nerve's
not coming back.
Not coming back. Okay.
Wow.
So it's phenomenal, and we've seen patients.
So everybody that doesn't know, like an RFA, typically the nerve's coming back in 6 to 12 months.
Correct. Correct.
So okay.
Some people get more or less than that, but that's
Yeah.
pretty standard. This is a permanent destruction of that nerve. It's only responsible for that. It doesn't do other things, so we're not worried about causing any sort of paralysis or permanent kind of problem. And our patients who have not had any luck, these are patients who have tried everything. I did epidurals, it didn't help. Maybe it helped for a few days. I did an RFA. It helped some, but not totally. It's because you're treating like a different type of pain, a different location of pain.
So you're really nailing the exact source of that pain.
Correct.
And this is disc type pain.
Discogenic, like
Discogenic.
degenerative disc
Yes.
type pain.
And they've tried epidurals, they've done all this stuff. Maybe they've done decompression, maybe even a mild. This is like what we're doing as a final thing.
Yep.
Okay.
It's such a permanent type procedure that insurance will not let you go back and do it again at that level if it's already been done. They're like, nope, it's been done. You can't go back in there and do that. It's just been amazing for us and for our patients. Again, it's patients that have struggled with this back pain. They've done all the other stuff. Nothing has helped them. It's now gotten more wide insurance coverage. It was just a Medicare, I believe, until this year. It's now been more widely accepted by insurances, and really is something that's changing how we practice pain from an interventional standpoint, and changing how we manage this anterior column pain. And this is something that 15 years ago wasn't even a thing. We didn't know about this. We didn't have a solution besides an epidural or maybe a disc injection, which didn't work great. And so it's just been one of those groundbreaking things, and it's still gaining traction. Like you said, there aren't a whole lot of providers in this area that are doing it. There seem to be pockets of areas where it's growing, and we hope to be the people in this area who can make this possibility for our patients.
I think that you're just doing an incredible job. You've really built this place up and created a reputation, and I'm looking forward to continuing to grow that with you and grow this company and really change medicine across not just this state, but across the country.
Yeah.
And I appreciate your time today. You shared a lot. You're extremely knowledgeable, and thank you very much for joining us today.
My pleasure. Always enjoy talking to you. Thanks for having me on, and let's go make some changes in the medication world.
Let's do it. Thanks, guys.